This lecture is on high-risk newborn, acquired and congenital conditions. High-risk newborn includes preterm infants and infants or full-term infants that were delivered with congenital conditions. Preterm infants are susceptible to development of things like necrotizing enterocolitis, bronchopulmonary dysplasia, intra and periventricular hemorrhage, and retinopathy of prematurity. And the primary reason is due to immaturity of their organ or system, and also due to the fact that they lack physiological reserve that is required to allow them to survive outside of mom. And if you recall, preterm refers to birth prior to the completion of 37 weeks. So we're going to go over some of the issues that are very common with respect to this high-risk newborn. The first one that we're going to talk about is respiratory issues in the newborn. Respiratory distress is one of the most common issues with neonates, and this is due to deficient surfactant to keep the alveoli open. Approximately 10% of newborns need some form of resuscitation immediately after delivery. However, majority of newborns will easily transition to extrauterine life, so all you have to do is to dry and stimulate the newborn and they'll just be fine. Now, sometimes respiratory issues could be due to narcotics that were given to mom during labor. Under such circumstance, Narcan or naloxone will be the medication of choice to reverse the respiratory distress in that newborn. Another issue is neonatal asphyxia. A neonatal asphyxia is the failure of lung expansion and establishment of respiration upon transition to extrauterine life. And this usually results in hypoxemia, metabolic acidosis, hypercarbia, which is excessive carbon dioxide in blood. If a baby was delivered prematurely, it is very, very vital that this baby receives surfactant. Now, if mom presents in preterm labor and she never received betamethasone, which is usually given to moms who present in preterm labor for the enhancement of the lung or the fetal lung maturity, it is very imperative that this premature baby receives the surfactant, and this surfactant will be given within 15 minutes of life. It's usually administered via the endotracheal tube. Additional therapies may be required in extreme cases, and this could include the use of ECMO, and ECMO is extracorporeal membrane oxygenation therapy, and this is a modified heart-lung machine, and some babies do benefit from this therapy. Transient tachypnea of the newborn. All infants who experience this transient tachypnea of the newborn usually develop rapid respiration immediately after birth. And the etiology behind this transient tachypnea of the newborn is pretty much unknown. However, the level usually resolves within 12 to 72 hours. There are some risk factors that can predispose a newborn to experiencing this transient tachypnea, and these include things like macrosomia. So when you have a baby that is a macrosomic baby, that is a risk factor. Multiple gestation, excessive maternal sedation, precipitous labor. So these are some of the risk factors that can predispose a newborn to experiencing this respiratory issue. So how do you know that your baby is experiencing TTN? Well, some of the signs and symptoms include grunting, chest retractions, nasal flaring, and mild cyanosis. So these are symptoms, basically signs of respiratory distress in newborn. Now, the management of TTN includes gavage or IV feedings if there is increased respiratory rate. Now, if the baby is cyanotic, oxygen needs to be given to the baby. If the baby is still struggling to breathe after extra oxygen has been given to the baby, then the baby might need what is called CPAP. And CPAP is continuous positive airway pressure. So this CPAP will help to keep the lungs from collapsing. With CPAP, a machine pushes a steady stream of pressurized air or oxygen through a mask to keep the lungs of the baby open during breathing. So this is basically what the management of TTN will be, but it will resolve most times, usually within 12 to 72 hours. Meconium aspiration syndrome. Meconium in amniotic fluid usually indicates fetal distress. So when a patient ruptures their membrane or they break their water, we try to find out what the color of the fluid is. Is it clear? Is it yellowish or greenish in color? When amniotic fluid is greenish or yellowish in color, that is known as a meconium-stained amniotic fluid, and that is an indication that there is some sort of fetal distress in utero. And so this meconium aspiration syndrome refers to a fluid aspirated into the tracheobronchial tree, either in utero or during first few breaths taken by a newborn. And so this is why it is very, very vital that if your patient is in labor and their rupture of membrane took place with meconium stained amniotic fluid, so they have a meconium stained amniotic fluid, it is very important to make sure that the NICU team members are in attendance during the delivery of the baby, because when the baby comes out, we have to assess the baby to see if the baby is vigorous or non-vigorous. In a non-vigorous baby who had a meconium stained amniotic fluid, all intervention needs to be started immediately in order to care for this newborn. So what are some of the signs and symptoms of this meconium aspiration syndrome? Well, the symptoms are pretty much mild to severe respiratory syndrome, tachypnea, cyanosis, retractions, nasal flaring. So these are the signs and symptoms of meconium aspiration syndrome. And your nursing care or nursing intervention varies on the amount of meconium that is aspirated. In utero, we do a procedure known as amnioinfusion. And so this amnioinfusion refers to the installation of fluid into the amniotic cavity. This procedure is typically performed during labor through an intrauterine catheter or IUPC that is introduced transcervically after rupture of the fetal membranes. So now when this baby is delivered, if the newborn heart rate is greater than 100 beats per minute, the baby is okay. There is no need for deep suctioning. However, if the heart rate is less than 100 beats per minute, then deep suctioning will be performed on the newborn. Assessment for signs and symptoms of respiratory distress needs to be conducted, and of course, supportive care will be needed if the infant requires mechanical ventilation. Pathologic jaundice or hyperbilirubinemia. Well, this portion actually was in the voiceover that I sent over to you guys in the voiceover under the newborn adaptation. But just a review, this pathologic jaundice is the type of jaundice that happens within the first 24 hours of life. So when a baby is delivered, you start to see the manifestations of jaundice. That is known as pathologic jaundice. It's usually caused by ABO incompatibility, RH incompatibility, or the erythroblastosis fetalis. Those are the causes of pathologic jaundice. And so this jaundice may be present at birth, and that is what the pathologic jaundice refers to. So when you take a look at this picture, you see the baby who is jaundiced, and the signs of this jaundice includes yellowing of eyes. So you see the yellowing of the sclera of the eyes, yellowing of the skin, and this is because of the excess bilirubin in the blood. So now if this excess bilirubin, if the bilirubin level continues to rise, to increase, drastically, it can reach to a level where the bilirubin now moves from the bloodstream and now goes or gets into the blood tissue. And when that happens, it leads to what is called kernicterus. And kernicterus is a brain damage as a result of excessive levels of bilirubin or bilirubin buildup in the newborn's brain. And so the treatment of this jaundice includes phototherapy, and I discussed phototherapy in the newborn adaptation lecture. Also, we do what is called exchange transfusion, and this exchange transfusion or blood transfusion is only needed in extreme cases. You need to monitor the bilirubin levels. Optimal nutrition is very important, and also to monitor for complications of kernicterus or brain damage. Untreated hyperbilirubinemia due to either the type of jaundice may result in neurotoxicity and subsequent death. Sepsis. Sepsis is another issue with high-risk newborn, and this is basically infection in newborn. And some of the causes of this sepsis includes chorioamnionitis, maternal temperature, group Bayer streptococcus, gram-negative organisms. And so when a baby has sepsis, you need to observe the baby for lethargy or irritability, color changes, pallor, duskiness, cyanosis, cool, clammy skin, hypothermia. Hypothermia is usually an indication of infection in a newborn, and this is due to temperature instability. So you need to keep an eye on the baby's temperature. Poor intake, diarrhea, vomiting, hyperbilirubinemia, tachycardia, bradycardia, or apneic spells. And of course, it is very important to send labs on the baby. So labs need to be drawn, such as CBC blood cultures, and also administration of antibiotics as ordered. So those will be your nursing care or nursing intervention in the setting of a newborn sepsis or infection in newborn. Now we're going to take a look at some of the common sexually transmitted diseases that affect the newborn. And if you recall, we covered some of this when we did maternal sexually transmitted diseases. Gonorrhea. Well, gonorrhea is a sexually transmitted disease where newborns born vaginally to infected mothers acquire infection. And so this is the reason why it is very, very essential, why it is a state mandate that all babies that are delivered here in the state of New York receives erythromycin to prevent them from getting ophthalmia neonatorum secondary to untreated gonorrheal or chlamydial infection from the mom. And so your infant assessment will include assessment of ophthalmia neonatorum or conjunctivitis, neonatal sepsis, temperature instability, poor feeding response, hypotonia, jaundice. And of course, you want to administer the medication and of course provide education to the patient regarding follow-up with ophthalmologist. Chlamydia trachomatis. Well, this is sexually transmitted disease acquired during passage through birth canal. Infant assessment will include assessing infant for pneumonia, conjunctivitis, and the nursing management once again includes the installation of the ophthalmic ointment, erythromycin, and initiation of follow-up referral. Infant of diabetic mom. Well, these are infants that are born to mothers that have diabetes. These infants really require close observation, especially within the first few hours of life to the first few days of life. And these infants can be small for gestational age, and they can weigh anywhere less than 2,500 grams, or they can be macrosomic infants weighing up about more than 4,000 grams. So it can be small or big babies. And also the infants born to mothers that have diabetes, they have certain cardinal characteristics. You never miss it. So these infants usually are macrosomic. They are more macrosomic than being small. And also they have this ruddy color. So they're very ruddy in color. They have excessive adipose tissue and large umbilical cord and placenta. So that's how usually these babies will present at birth. Now there are some complications that goes along with this. Hypoglycemia is one of the complications. This is when you have a drop in the blood glucose level of a newborn or anybody. So hypoglycemia is a complication. Birth trauma is also another complication. And we have respiratory distress syndrome. And in this syndrome, basically the insulin antagonizes cortisol stimulation of lecithin, which is needed for lung maturity. So what will be your nursing care if you have a baby whose mom is a diabetic? Well, you want to encourage breastfeeding or bottle feeding. So the baby needs to be fed. You want to check vitals per protocol, check blood glucose level per protocol. Usually when babies are born to moms who are diabetic, within the first 24 hours, we have to monitor their blood sugar level every 3 to 4 hours. And you need to also observe for signs and symptoms of hypoglycemia. And now when a baby is hypoglycemic, usually hypoglycemia in newborns refers to a blood glucose level that is less than 45 milligram per deciliter. So now you have a baby that is hypoglycemic. What will you see? Well, the baby will have some tremors. The baby will be jittery. So you have a baby that is shaking up a stomach, baby that is jittery. Those are hallmark signs of hypoglycemia in newborn. So you want to check the baby's blood sugar level. You want to encourage the mom to feed the baby because you need to bring the blood glucose level up. Polycythemia. Well, this polycythemia is a condition in which blood volume and hematocrit values are increased above the normal limits. So the blood volume and hematocrit of the newborn, they are way above the normal limits. And the extra cells cause the blood to be thicker, and this in turn increases the risk of other health issues such as blood clots. So what are some of the causes of this polycythemia in newborn? Well, some causes include post-maturity, and post-maturity will be a baby that is a newborn that was delivered more than 42 weeks gestation, diabetes in the mother, delayed cord clamping. And so with delayed cord clamping, too many red blood cells travel from the umbilical cord to the baby before the cord was clamped. So these are some of the causes of polycythemia. Another cause of polycythemia is the twin-to-twin transfusion syndrome. So twin-to-twin transfusions is also a cause of polycythemia. So what happens is that in twins-to-twin transfusion syndrome, it occurs when blood moves from one twin to the other. The twin that loses the blood is called a donor twin, and the twin that receives the blood is called the recipient twin. Now, both infants may have problems depending on the severity of the transfusion. The donor twin may have too little blood, and the other may have too much blood. The donor twin may need a blood transfusion, while the recipient twin may need to have the amount of blood in his or her body reduced. And this is usually caused by abnormal connections of the placenta. So what is your nursing care in the setting of polycythemia? Well, you want to assess for signs and symptoms. Ruddy appearance is one of the signs. Lethargy, enlarged heart, hyperbilirubinemia. So these are some of the things that you have to look out for in a newborn. If they are present, those are indicative of polycythemia. And of course, you need to draw labs to interpret the values. A normal red blood cell at birth ranges anywhere from 5.1 to 5.3 million per millimeters cube. So this is what the normal red blood cell will be. So anything more than this level will be an indication of polycythemia in a newborn. The drug-exposed infant. Well, substance abuse affects the fetus at any time during pregnancy. If you remember clearly when we covered pregnancy, we said that the fetus or the fetus is mostly vulnerable during the embryonic stage, and this is the first few weeks after conception. So if mom abuses any substance, it will affect the fetus, especially during that period. However, it can still have effect on the baby at any time during the pregnancy. And so there are some common drugs that are abused by moms or pregnant women. And some of those drugs include marijuana, methamphetamines, heroin, cocaine. So these are the common drugs that are abused. And so some of the issues associated with this drug exposure is neonatal abstinence syndrome, known as withdrawal. So when these babies were in utero, they were exposed to all these substances. When the baby is delivered, the baby will now withdraw from the drug exposure. There are some signs and symptoms of intrauterine drug exposure. And so this intrauterine drug exposure can cause congenital anomalies on these babies. Signs of intrauterine drug exposure includes behavioral symptoms. With regards to behavioral symptoms, you will see irritability on the newborn. So irritability, jittery, muscular rigidity, convulsion, restlessness, exaggerated motor reflex, high-pitched cry. Now these babies are screamers with the high-pitched cry. So you hear this kind of annoying screaming cry, which can drive you crazy. But unfortunately, it's not the baby's fault. These babies are just victims of circumstance. But those are some of the withdrawal symptoms that you will see in these babies who were exposed to drugs. Now, there are some feeding signs you will see. They'll have exaggerated rooting reflex, uncoordinated rooting, frequent diarrhea, weight loss. There are respiratory signs and symptoms. These babies will present with nasal stuffiness. They sneeze a lot, so excessive sneezing, frequent yawning, tachypnea, retractions, and in some babies you may even see hypertension, fever, diaphoresis, and mottling. So all these are signs and symptoms of withdrawal or intrauterine drug exposure in newborns. So the management of these drug-exposed infant includes medication. So you want to administer medications to these babies. Sometimes the doctors may order morphine for them. They may give them methadone, or sometimes they may order phenobarbital, which is an anticonvulsant. IV feedings if needed. You want to minimize environmental stimulation, so reducing stimuli is very important. You need to schedule feedings, and of course you want to allow the mom to bond with their newborn. Swaddling the baby, holding the baby will help to reduce or will help to keep the newborn calm. So these are some of the interventions that one have to implement in the setting of a drug-exposed infant. And of course, sometimes you may see a baby with a fetal alcohol syndrome, and these fetal alcohol syndrome babies will present with small eyes, thin upper lip, and short nose. So these are some, unfortunate circumstances that some of our babies have to deal with. And it's very important for you to know how to manage the babies that are exposed in utero to these substances. Other newborn-related issues. Well, the first one there is PKU. Or PKU is a genetic disorder that causes central nervous system damage, and this can result in severe intellectual disabilities in a baby or in a child. And so the most important thing to remember about PKU is that all babies are screened immediately after birth for this genetic disorder, in addition to other genetic disorders. Now, if a baby is diagnosed with PKU, the baby must not be breastfed. Breastfeeding is contraindicated in PKU, whether it is the mom or the baby. This baby, once the baby is diagnosed with PKU, the baby needs to be placed on a special formula. The baby needs to be on a low phenylalanine diet. And this is a special formula which is initiated when the infant is around 3 weeks old. So no breastfeeding for a baby who has a PKU or mom has a PKU. Cleft lip or cleft palate is another issue. related to newborns. With cleft lip and cleft palate happens due to failure of the palate to close, and with the cleft lip there is opening on the lip. So with these conditions, surgery is very, very important. So you need surgeries to repair these issues. Surgical repair of cleft lip will occur around 3 months, while the palate repair will be around 14 to 16 months for the hard palate and 18 months for the soft palate. So both need to be surgically repaired. And by the way, if a baby has a cleft lip, it actually affects feeding, especially if the baby is a breastfeeder. Because if you have to breastfeed, you need to form a seal around the breast around the nipple in order to breastfeed. So if there is an opening on the lip, it becomes daunting to breastfeed this baby. But there are interventions that may be given to the moms who wants to breastfeed. It's much easier to breastfeed in a baby who have a cleft palate than a cleft lip. This condition too may affect bonding, so it's very essential to encourage mom to bond with her newborn. The mom may be disappointed that the baby has a deformity. Encourage mom to bond with the baby. Remember what Erik Erikson states, that when a baby is delivered, that the baby starts to learn to trust versus to mistrust. So when a baby doesn't experience that bonding, that relationship with the mom, that could lead to failure to thrive, and that is not good for the newborn. Other issues include cardiac defects, and these cardiac defects could be acyanotic defects, and with acyanotic defects, there is obstruction of blood flow from the left side of the heart, such as seen in ventricular septal defect or PDA, patent ductus arteriosus. And with the PDA, I covered this in the lecture with the newborn adaptation. Usually, the ductus arteriosus will close around 15 hours of life after delivery. However, if this PDA or if this ductus arteriosus remains patent, it has to be closed. So in order to encourage the PDA to close, IV ibuprofen or IV indomethacin needs to be given to the baby. So we administer IV ibuprofen or IV indomethacin to the baby to encourage the PDA to close. Now, if these medications do not help to close the PDA, surgery will be required to close the ductus arteriosus. We also have cyanotic defects, and in these cyanotic defects, the blood flow to the lungs decreases, or venous blood and oxygenated blood mixes. There is tetralogy of Fallot, and this tetralogy of Fallot is a combination of 4 heart defects that are present at birth. This includes the overriding aorta, transposition of the great vessel, pulmonary valve stenosis, right ventricular hypertrophy, and ventricular septal defects. And you're going to cover this more in depth in PEDS as you guys progress or move on to PEDS. Now, there are other issues too, though not on your PowerPoint, but I'm going to go ahead and cover this. We have what is called ROP, or retinopathy of prematurity. So this retinopathy of prematurity is a potentially blinding disease caused by abnormal development of retinal blood vessels in premature infants. So retinopathy of prematurity is a potentially blinding disease caused by abnormal development of retinal blood vessels in premature infants. So what are some of the symptoms of this ROP? Well, symptoms include unusual eye movement. So the baby will exhibit unusual eye movement, vision loss, wide pupil. Those are symptoms of ROP. And the risk factors for this retinopathy of prematurity includes prematurity, low birth weight, and too much use of oxygen, especially during resuscitation of the premature baby. So it is very imperative to avoid too much oxygen in premature babies. In these tiny infants, we need to avoid too much use of oxygen because this can cause babies to lose their sight. The good thing is currently we don't even give too much oxygen to our babies anymore. So the use of too much oxygen in those days led to babies becoming blind as a result of ROP. So this retinopathy of prematurity, the key things to remember is that you need to avoid too much use of oxygen. Know the risk factors, that prematurity is a risk factor, low birth weight, and the excessive use of oxygen, and of course the symptoms. Another issues related with newborn includes gastroparesis. Gastroparesis is a defect at the umbilical insertion site with full herniation of abdominal contents, usually the intestine. So the intestine is protruding through the side of the umbilical ring. And babies who are diagnosed with this gastroparesis usually is diagnosed with ultrasound. So when a baby has a known gastroparesis, these babies need to be delivered via C-section because the abdominal content is open, everything is hanging out. So there is a full herniation of abdominal contents, the intestines, through the side of the umbilical ring. So these babies, once they are delivered via C-section, they need to go in for an immediate surgery because those contents, abdominal contents, need to be put back inside. So they need to go for surgery immediately. So that's what the gastroparesis is, and I think you guys will revisit this again in PEDS. So now we talked about some of these issues with our high-risk newborn. These issues can trigger some sort of grieving process on the part of the patients or the parents. So the parents may grieve the loss of the newborn, not necessarily that the newborn died, but grieving can be as a result of losses for what was hoped for, something that was dreamed about or planned. Imagine a woman who delivered a premature baby. She can experience a sense of loss of control. The birth of a baby with a defect or illness will cause the parents to grieve over the loss of their perceived ideal child. You know, when a woman is pregnant, she is dreaming about this perfect baby, this ideal child. And imagine if you delivered a baby with any of these disabilities or any of these issues. That could cause or trigger some sort of grief. So what is our role as nurses? Well, our role as nurses is to help actualize the loss. So we need to avoid saying things like, especially in the case of a stillbirth or a demise or a neonatal death, we need to avoid saying things like, well, the baby is now in heaven, or God was looking for an angel. Those things actually doesn't make sense to say things like that because it actually helps aggravate the situation. Being silent can be the best support. If you don't know what to say, just be silent. Your presence matters. Your presence in that patient's room matters a lot. You could just be quiet. Listen to the patient. Help parents express their feelings. And of course, you want to encourage bonding with a baby with defects. So you have a baby with cleft lip, like I mentioned before, cleft palate, all these cardiac defects that we talked about. You need to help the patients and encourage them to bond with their child so that they have to, establish that trust. And of course, you want to be respectful of spiritual and cultural values of the parents. If it is a stillbirth, we usually create what is called mementos. So we create mementos for the parents to take home. We give them information about support groups. And of course, we usually allow them time and privacy to grieve. So this is the end of this lecture on highborn or high-risk newborn and other related issues. Please take the time to listen to it and listen to it again because that is very, very helpful.